Good evening, everybody. Happy holidays to all of you, and thanks so much for joining us, especially during this busy holiday season. Softbones is pleased to have you on this next topic of our ongoing webinar series, this time with a focus on eye health. The topics of these webinars were determined by our region leads with input from you. So if you have a topic that you'd like to hear, please reach out to your region lead and make sure you let them know so that we can put you into our 2021 roster. Dr. Rallo joins us tonight. He graduated from the University of Missouri College of Optometry and has since remained in St. Louis to build upon his impressive career. He's currently the senior pediatric optometrist at St. Louis Children's Hospital and Shriners Hospital, also in St. Louis. And he's an instructor of ophthalmology and visual sciences at Washington University. Dr. Rallo joined us at our Softbones Global Scientific Meeting back in 2018 in Chicago. And tonight he brings his expertise to us, and we are so glad to have him with us tonight. So before I pass the baton over to him, just a couple quick housekeeping items I want to go over. You should all be muted upon entry to the meeting. In case for some reason you unmute, we just ask you to make sure that on the bar on the Zoom screen that you hit the mute button so that we can minimize background noise. To familiarize yourself with Zoom, there is a toolbar by that mute button. There should be a chat function there. If you have any questions during the presentation, we ask you to go ahead and put them into the chat function and we will read them at the Q&A, again, to minimize noise and back and forth. At the conclusion of the meeting, after the Q&A session, at the conclusion of the presentation, I should say, you'll be automatically directed into breakout rooms with your region leads, and that will allow you to continue the conversation, talk about other topics that you may want to hear. So it's a nice chance for us to be able to continue talking and to connect a little bit. The presentation is going to run for a half hour. We've left 15 minutes for Q&A, and then we leave the breakout rooms open until 8 o'clock, but usually we leave them open a little bit longer than that, but we'll give you a countdown and adequate time so you know when that they're going to shut down. So without further ado, Dr. Rallo, we'll let you take it from here.
Thank you so much, Deborah. I really appreciate that introduction and the chance to talk tonight. So I welcome everybody to tonight's Zoom meeting. With the pandemic, this seems to be a very common occurrence. So what I'm going to talk about tonight are the potential ocular findings associated with both hypophosphatasia and its treatment. And I apologize, as Deborah said, we are having some technical issues, so my video camera is not working. I'm also not able to advance my slides, so Deborah has kindly agreed to do that for me. So as she said, I am the senior pediatric optometrist at St. Louis Children's Hospital and Shriners Hospital in St. Louis. So these are my two homes away from home. Next slide. So I did want to point out, I was a consultant briefly for Alexion Pharmaceuticals in 2013, and my role at that time was to fine-tune the eye exams that were being performed as part of the Innovia study. So I did want to mention that. Next slide. So I am going to talk a little bit about hypophosphatasia, although I would not be surprised if most or all of you are more familiar with this disease than I am. But I thought it was important, rather than just jump right to the ocular findings, that we kind of talk about hypophosphatasia and the mechanisms that are involved and, of course, the treatment. So again, as you know, this is a very rare genetic disease that results in the abnormal mineralization of both bone and teeth. Next slide. So a few points I want to make about hypophosphatasia. First of all, the severity of the disease is quite different from individual to individual, and it seems to be dependent mostly on the age of onset and the inheritance pattern. So individuals who have early onset, and this would be obviously children born with it or developing it early in childhood, tend to have the most symptoms. And those that have autosomal recessive inheritance also tend to be the worst cases as well. And as I said, the expressivity of the disease tends to be quite variable depending on these issues. And it can be as mild as just simply having dental issues as an adult to very severe, even resulting in death in newborns. And there's actually a fairly equal distribution between both males and females. So what causes hypophosphatasia to develop? The key is the ALPL gene. And there's a mutation of this gene that causes the disease hypophosphatasia to develop. And so there's an enzyme called TNSALP, which stands for tissue nonspecific alkaline phosphatase. And this enzyme is necessary for the normal mineralization of both bone and teeth. However, because of the defective ALPL gene, this enzyme is actually not made because the gene ALPL is responsible for the production of TNSALP. So because of that mutation, the enzyme is not produced, and therefore there's abnormal mineralization of bone and teeth. And how rare is hypophosphatasia? I mentioned it's a very rare disease. It's estimated that about 1 out of 200,000 live births will have this condition. However, in Manitoba, Canada, where there's a very high Mennonite population, it's actually 1 out of 2,500 live births, so much more common in that population. The fact is that these numbers are probably skewed towards the low side because of a number of either undiagnosed or misdiagnosed cases. So let's get into the genetics, and nobody likes this part. This is confusing, so I'm not going to get too into this, but I did want to just briefly give you an overview. So the two causes for hypophosphatasia can either be autosomal dominant inheritance or autosomal recessive inheritance. And as I mentioned, the recessive inheritance tends to be a much more devastating disease. So with autosomal dominant, if you look at the top diagram, if you have a parent who has this mutated gene, 50% of your children could end up having this condition. The other 50% would be completely unaffected. It's a little bit different with autosomal recessive inheritance. Generally, you would have both parents would need to have this mutated gene. 50% of their children would be carriers of the disease. 25% of children would actually have the disease, and then 25% would be completely unaffected. So there are currently 6 classifications of hypophosphatasia. There initially were 5. So there's prenatal, perinatal, infantile, child, and this is where the change was made. They've now broke this category down into both mild and severe. And then of course, adult and odontohypophosphatasia. So how is hypophosphatasia diagnosed? It's actually a pretty challenging condition to diagnose. And so a lot goes into these exams. So first off, there has to be a very detailed history done by your physician and an extensive clinical evaluation as well. And then this is generally supplemented with x-rays, lab work, and histopathology. So again, it's not out of the question that there are cases of hypophosphatasia that, again, have either been undiagnosed or misdiagnosed. So as I said, it's a pretty complex exam to arrive at this diagnosis. So what is the treatment of hypophosphatasia? So before the enzyme replacement therapy was approved by the FDA, basically treatment was directed towards either specific issues or complications that were associated with the disease. There really was no treatment for hypophosphatasia, the disease itself. And then of course, during the Enobia study where aspartase alpha was being tested as a potential therapy, we were able to, as a result of that study, determine that it was safe, it was very effective, and as I said, ultimately approved as Strensiq in 2015. So I wanted to put this slide in here, and again, you've probably seen variations of this from time to time, but this was a young lady's hand, and this was actually on ABC News several years ago during one of their presentations, and it just gives you an overview of how effective this enzyme replacement therapy is. So prior to treatment, this is what this child's right hand looked like, and you can see the abnormal bone development very minimized. And after just 6 months of treatment with Strensiq, you can see the bone formation. It's really amazing. I remember Dr. White, who I'm sure most of you are familiar with, Dr. Michael White, who is a renowned expert on hypophosphatasia. I remember talking to him and him showing me some of the results, and it was astonishing to me. It's really amazing. So what was the Enobia study? So myself and one of my colleagues, Dr. James Hochul, we're both pediatric optometrists. We were invited by Dr. White, who is also based out of St. Louis, to participate in this study. And our role was obviously to perform my exams. What was amazing and a little bit humbling to both of us was that we were the only 2 eye doctors who were seeing pediatric patients in the entire nation. So we felt very honored to be part of the study. We started enrolling patients in April 2010, and we enrolled our last patient in August of 2016. There were a total of 21 patients that were enrolled. The presenting age ranged from anywhere from 3 to 14 years. All of these patients were placed on aspartase alpha at some point. And again, that was the name that the treatment was going under prior to approval. Eye exams were conducted every 6 months, and the pupils were dilated every 12 months. And now I'm going to get into a little bit more about the exam and more specifically about the conditions that we're looking for. So there were 3 primary ocular findings that we were looking at. One was ectopic calcification, and basically that just means the deposition of calcium in areas where it hadn't been before or shouldn't be. A condition called optic atrophy, and then thirdly, what we refer to as angioid streaks. So we're going to talk about ectopic calcification first. So, and I hope you can see this. Unfortunately, not only can I not advance my slides, but obviously I can't use my laser pointer either. But if you look just to the right of the color part of the eye, you'll see these little areas. They almost look like small cysts. And so those are the calcium deposits that were being found during this study. They're superficial, so they're actually on the conjunctiva. And just so you know, the conjunctiva is just a thin membrane that covers the white of the eye. And so again, these were very superficial. They were benign. They were not causing any type of eye irritation, redness, and certainly did not result in any vision changes whatsoever. Next. So calcification, obviously, of the conjunctiva, as I just showed you, but you can also have calcium deposition of the cornea. And so I wanted to show you this diagram just to kind of get you acquainted with the area that I'm speaking of. So to the left is the front of the eye. So the cornea is the clear watch crystal of the eye. And this is where, for instance, a contact lens would sit. The cornea, again, is clear tissue, and it vaults over the iris, the color part of the eye. And so the back of the eye, that is where the optic nerve enters and connects the eye to the brain. And then there are actually 3 layers of the eye itself. There's what's called the sclera. That's the outer white part of the eye that you obviously can see. There's a middle layer called the choroid. That's a highly vascularized tissue. And so a lot of blood vessels in that area. And then the innermost layer is called the retina. And we're going to be talking about the retina in just a bit as well. So let's talk about the cornea and the calcium deposition that we were looking for there. So technically we call this band keratopathy. And again, if I had my laser pointer, I could show you exactly where it's at. It's right at the edge of the iris, the color portion of the eye. And it's at about 9 o'clock. And again, I apologize, I can't specifically show you where that's at, but it's very peripheral. Calcium deposits on the cornea can impact vision, particularly if it's centrally located and blocking the pupil. And I'm going to show you a slide here in just a moment that demonstrate that. But in this particular case, and this was the only patient out of the 21 that I saw that had this condition. Again, it's not so much on the white of the eye, it's actually right at the peripheral edge of the cornea. And so let's go ahead and advance to the next slide. So this is much more extensive band keratopathy. This is a slide that I downloaded. This was not a patient who had hypophosphatasia or who was on treatment, but I just want to show you a more extensive deposition of calcium. And so in a case like this, certainly vision could be impaired. Fortunately, there is a treatment called chelation, which involves chemical treatment with EDTA, and you can actually remove a lot of that calcium deposition and clear the visual axis so that vision's improved. But again, the one case that I saw this, it was confined to a very small peripheral region and never advanced during the time that I followed this particular patient. So next slide. So that was the first thing we were looking for. The second thing we were looking for is what's called optic atrophy, and this is going to be a little bit more involved. So if you look at the top left slide, that is a very healthy, normal optic nerve that you see there. It's that round disc, and you can see the blood vessels coming out of the optic nerve. That little area of yellow that you see right in the middle of the optic nerve, that's what's called the cup. Everyone has cupping of the optic nerve. This is kind of off the subject, but people that have glaucoma or elevated pressure in their eyes, that cup can become very enlarged. And so that can be an indication of elevated pressure or glaucoma. But again, that's a very healthy nerve. If you look at the bottom left slide, if you look at the nerve, it is exceedingly pale. So there has been some type of insult to the optic nerve for it to look like that. And there are a number of causes that can result in optic atrophy. Unfortunately, there's no definitive treatment. Steroids are sometimes indicated if it's caught early enough, but even with that being said, we really don't see a lot of improvement. And so this can actually be irreversible in terms of vision loss. So this is a key factor when we're dealing with patients who have hypophosphatasia. So one of the keys with this is that, you can stay on this slide, Deb. So one of the keys with hypophosphatasia is that you can develop hydrocephalus. And so the next couple slides, we're gonna talk a little bit about that. So there's a condition called craniosynostosis. And I actually have some, what's the word I'm looking for? Some information, some facts, statistics, there we go, from Dr. White, and I'll be talking about that here in just a moment. But craniosynostosis, so when we're born, the skull is actually not completely fused. There are multiple fusion sites, or what we refer to as sutures. And so there's the coronal suture, the frontal, the sagittal suture. There's also what's called the squamosal suture and the lambdoid suture. So the brain is actually, or I should say, the skull is actually divided into pieces, so to speak. And fusion doesn't result or complete until late teens in most individuals. And the reason why the sutures are there is to allow the increase in size of the brain as we grow. And so what we see with craniosynostosis is there is some premature fusion of one or more sutures, and this can result in what's called hydrocephalus. Hydrocephalus is abnormal accumulation of fluid in one or more ventricles of the brain. And on this slide to the right, you can see there's the ventricles of the brain. There's the lateral, the third, and the fourth ventricle. And so if fluid accumulates in these ventricles, that can cause what's referred to as hydrocephalus. And that increased pressure can actually damage the optic nerves, thus resulting in optic atrophy. Next slide. So this was the statistic that I was talking about. This is from Dr. Michael White's paper in 2014 entitled Hypophosphatasia, a retrospective natural history study of the severe perinatal and infantile forms. And he went back and looked at patients who were 5 and under with the condition hypophosphatasia, and he found out of 31 patients, 19 of them had craniosynostosis, or 61%. So that's quite high. And so that's one of the reasons why we were very much interested in whether there were cases of optic atrophy, and we'll talk a little bit more about that. Next. So the final thing that we were very interested in was the development of what we call angioid streaks. So I have listed here Brooks membrane, and you may remember I listed there were 3 areas, 3 layers, I should say, of the eye. There was the innermost layer, the retina, the outermost layer, the sclera, and then the innermost, or the middle layer, is the choroid. Brooks membrane is a thin layer of tissue that separates the retina from the choroid. And one of the things that can develop from abnormal calcification is that the Brooks membrane can become very brittle, and it's almost like a cracked earth appearance. So if you look at this slide that I have here, you can see the nerve, and I'll be real honest with you, that optic nerve doesn't look good to me. That's a pretty pale nerve. Again, this is not one of my patients through in the study. This was just taken off the internet. But if you look, in addition to the blood vessels coming off the optic nerve, you'll see these areas of brown kind of radiating from the optic nerve. And that's where there's actual breaks in Brooks membrane. And the concern is not so much those cracks, because they're really not harming the eye. The problem is where that occurs, you can develop what's called a choroidal neovascular membrane, or CNVM. And when you have a membrane like that, it's abnormal development of blood vessels, and those blood vessels are certainly not stable like the normal blood vessels in our body, and so they tend to rupture and bleed. And with the bleeding, particularly if it occurs in what's called the macula, which is a specific area of the retina, you can have pretty significant vision loss. So I'm going to go through statistics here in just a moment and kind of break down what percentage of kids that we saw had angioid streaks, optic atrophy, and calcium deposits. So we can go to the next slide. So what were our findings from this study? So again, we had 21 patients total that we saw, pediatric patients. When it came to ectopic calcification, we had about 67%, or 14 out of 21, who had signs of this. A couple interesting points I would make, and I kind of referenced this earlier. Only one of the patients had calcification of the cornea, and again, it was very, very mild. The rest, it was on the conjunctiva, or the clear tissue that covers the eye. I think this is also very important to point out, that 67% is a pretty high percentage. However, of the 14 patients who had ectopic calcification, 9, or 64%, had evidence of calcium prior to the start of the enzyme replacement therapy. So that was, again, very important. We had 3 patients who were diagnosed with optic atrophy. 2 had a history of hydrocephalus, and as I mentioned, with hydrocephalus, it's not uncommon that we'll see optic atrophy. So about 14% of our pediatric patients did have optic atrophy. The other child who had it, we suspect he had dominant optic atrophy, which is completely unrelated to hypophosphatasia. It's actually a heritable condition, and his father had it. So based on our testing, we really felt like this was not related at all to hypophosphatasia, but it was in fact something completely different. As far as angioid streaks were concerned, none of our patients showed any evidence of that. So I wasn't going to put this slide in, and I thought if I have adults, I think it's probably something they would be interested in. So again, Dr. Hochul and myself saw almost exclusively pediatric patients. However, I did see 7 adults ranging in age from 24 to 68 years. 5 of those 7 patients had calcium deposits. Again, these were primarily on the conjunctiva. I did not see any corneal findings in these patients. And again, this is a really important point here. Of the 5 patients who did exhibit calcium deposits, 3 were not even on aspartase alpha at the time. And we did not find angioid streaks, nor did we find optic atrophy in any of those 7 patients. So what conclusions can we draw from the Enobia study? So it's obviously clear that the disease process itself can cause ectopic calcification. And we can see that because we had several patients who had evidence of this prior to the start of treatment. Therefore, what is less evident is the correlation between treatment and ectopic calcification. So is it possible that treatment may have caused calcium deposits to develop? It is. Or was this possibly just from the disease process itself? And it's really hard to tease that out. But the bottom line is that when we did see the calcification, it was very mild. It did not seem to be progressive. Patients were asymptomatic. They didn't have any vision issues whatsoever. And so I thought those were, again, pretty important findings there. So this was a quote from, again, Dr. Michael White, who I view as the guru on this. And again, I thought this summed things up pretty well. Aspartase alpha was invariably associated with development of mild focal conjunctival calcification, likely through disinhibition of hydroxyapatite crystal propagation. The calcifications were not symptomatic or vision threatening and should not preclude enzyme replacement therapy for patients with this rare and often debilitating disease. Next slide. So aspartase alpha was approved by the FDA in 2015. It received breakthrough therapy designation during the investigational process, and of course you know it as Strensiq. And again, I was amazed to see what this medication was doing for patients and families, and it was just an honor to be part of this study. And fortunately, we really didn't see any serious eye findings from it. Next slide. So before I get into my acknowledgements, I did want to point out a few things because I've told you some of the things that we can see with the eyes. And I apologize, I don't have a slide for this, but I did want to just mention a few things for people who are concerned if they develop any of these 3 entities I've talked about, is there any treatment? So for the calcium deposits, in general, if it's on the conjunctiva tissue, typically, again, they're not irritating, they're not cosmetically unappealing, so on and so forth. So generally speaking, you're not really going to treat these. However, they can be removed from the surface of the eye with a small needle and some topical anesthesia. As far as that calcification of the cornea itself, again, if it begins to threaten vision, there is treatment with the chemical EDTA that can be performed. Again, optic atrophy, really no good treatment for that, unfortunately. And then for the angioid streaks, there's actually a few things that can be done. There can be injections of what's called anti-VEGF. So VEGF is responsible for the growth of vessels, blood vessels in the back of the eye and elsewhere. And so these injections can actually reduce the growth and slow the leakage of these abnormal vessels if in fact one develops. There's also what's called photodynamic therapy, and a photosensitive drug is actually injected into the arm, and it goes into these abnormal blood vessels. Those abnormal blood vessels, and it can activate this medication, which subsequently, again, destroys those abnormal blood vessels. And then finally, there's what's called thermal laser, which is a higher intensity laser. And again, the idea is you destroy those abnormal blood vessels so they're not able to leak and cause vision loss. So again, I'd like to thank Deborah and the entire Softbones organization. They do an amazing job, and it has been a pleasure working with them. Of course, Dr. Michael White, and his knowledge is never ending. I've picked his brain on more than one occasion, and it never fails. And then I also want to thank my colleague, Dr. James Hochul, who saw some of these patients along with me. So I think that is the end of my presentation.
Awesome. It was so great. I mean, such good information, and you presented it in a way that was very digestible and understandable. So thank you for that.
You're very
Uh,
welcome.
we did get a couple questions, so I
Sure.
want to open it up. One of the first questions I want to just ask is something that we've seen asked repeatedly in some of our patient meetings and on our boards, and that's just about the frequency of eye exams and how often patients, should be going. I know a lot of folks who were involved in the clinical trials had frequent eye exams as part of their clinical trial check-ins. And so that started the question, is this normal, and should we be going to have, some sort of HPP related eye exam done? What would be your advice to patients, both on or off therapy, about the frequency of eye exams? And then there's also a question related to that about the type of eye exam. Do you need to go to a special doctor for these types of exams?
So I would tell you that, in my opinion, given the potential findings that we have with this disease, honestly, I think annual eye exams would be indicated. But I will tell you this, whether you see an optometrist or you see an ophthalmologist, when you tell them that you have hypophosphatasia, they're probably not going to be very aware of it. Or if they are, they're probably going to have very limited knowledge. I had never heard of it. I've talked to several of my colleagues who had never heard of this disease. And so I don't know, again, that I would necessarily push you in the direction of an optometrist versus an ophthalmologist, but I would tell you dilation should certainly be part of that eye exam. So I do know that some of the community optometrists, dilation is not part of their normal exam, but if it's a doctor you've seen before and they do dilation, then I think I would be comfortable with you seeing them. If you've never been to this doctor or they've never dilated you in the past, I would definitely ask them to dilate your eyes, because some of these things like angioid streaks and optic atrophy, not so much, because you don't really need the pupils dilated to see the optic nerve, but to see things like angioid streaks are not going to be very easy if you don't dilate. And so that would be the thing that I would recommend. And I was just going to throw this out. If you have an eye exam and your doctor has questions, I would be more than happy to talk to them if they had questions or concerns about the findings. But like I said, I would venture to say that 99% of eye doctors are going to have little or no knowledge of this disease. Doesn't mean they can't check your eyes, certainly. But again, they're probably going to go to the books and do a little research and have a little bit more information. I've actually been debating about putting out a paper on this. Now, I know there's one that's already been published by Dr. Batty at Duke University, but he saw mainly adults, and so I kind of felt like that was geared towards adults. But there really hasn't been a paper regarding the eye findings in hypophosphatasia published yet, and I kind of feel like that's probably something I need to do. So
Yeah.
that answers the question.
Yep, absolutely. And then another question, just in terms of the eye appointment and the specialists, again, is it a normal eye appointment, or is it to look for something like nerve atrophy, or do you need an optic nerve specialist, who looks with fluorescence and, additional equipment?
Sure. So no, I don't think they really need to see a specialist. These are things that should be able to be detected during a normal exam. Again, that would include dilation, but I don't really think to visit an eye doctor that you have to see a retina specialist necessarily. I would actually discourage that.
Okay.
If they see something like optic atrophy or they see something like angioid streaks, then certainly more testing may be necessary and a referral to a retina specialist might be indicated, or even a neuro-ophthalmologist. But I think, just for your annual eye exams, again, I don't think that you have to, set that up with a specialist per se.
Okay, great. Another question, could an ulcer on the eye actually be a calcification?
Not unless it's misdiagnosed. A corneal ulcer is actually an infection. And so that's going to have a much, much different appearance than calcium on the cornea. So I would say if your doctor feels you have or have had a corneal ulcer in the past, I would say that's much more likely than just calcium. The appearance is going to be quite different.
Okay. And then do any of your patients have any issues wearing contacts?
Are you talking about my hypophosphatasia patients?
Yes, I think patients who maybe
Okay.
have these, these
Okay.
ectopic calcifications, does that
So
cause any issue with?
that's actually a really good question. So I would tell you I don't think so much the calcium on the cornea unless it's significant. But if you have calcium deposition on the conjunctiva, it could impact the fit of the contact lens and could possibly cause you to have more irritation with the contact lens that you would have, obviously without the contact lens, you probably would have no sensation at all. But it's possible that depending on where the calcium deposits are and how significant they are, that they could affect, particularly a soft contact lens. Yes.
Okay. Here's another one. My ophthalmologist office has vision exams and medical exams. What's the difference?
Well, that's an interesting question. So, I can only speculate what the difference is. It's very possible that their vision exam may not entail a dilated exam. To be honest, I've never heard that where an office has a vision versus a medical exam. So typically speaking, I would say again, it's all speculation on my part, but I would venture say a vision evaluation is going to be a more basic evaluation and may not entail dilation, whereas a medical exam, there's probably going to be more testing, particularly with the health of the eye, and that would certainly require dilation.
Okay. Another question, if you didn't have any or see any evidence of the angioid streaks in the trials, why is that one of the things to watch out for?
So that's absolutely true. So we did not see any in the pediatric population. I don't have, obviously, because I only saw a handful of adults, and to be honest, that was like one exam for each of the adults. And that was just a special request from Dr. White. So just because we didn't see it during the study on that limited group of patients, it still doesn't preclude those patients from developing it later in life. So that's why it's really important to have those, I'm not even going to say frequent eye exams, but maybe every one to at the most every couple years, I think an eye exam would be indicated.
Yeah, and if just a question about that, if they do have those eye exams and something is found, is this something that a traditional ophthalmologist can treat, or should they consult with somebody like you who has that HPP expertise?
So if I would say if something like angioid streaks or optic atrophy are detected, then probably referral to either a retinal or neuro-ophthalmologist would be indicated.
Okay.
And so I would tell you that with the calcium deposits, unless, like I said, they're impacting vision or causing irritation, there's really no treatment necessary for those two things. And probably a general ophthalmologist could treat that, to be honest with you.
Okay.
When you're dealing with optic atrophy or certainly angioid streaks, again, that treatment is probably going to be better suited to a retina specialist, yes.
Okay. Do you think that we should ask or alert our eye doctors to these, 3 problems that you indicate? Is that something we should be pointing out, or, you think they would
Right.
be looking for that?
Well,
anyway?
No, I to be honest, like I said, I have a feeling that not only are they not going to be familiar with hypophosphatasia, I think it's going to be even less likely they're going to be aware that these ocular findings can be found in these patients.
Yeah.
It's not that, if they do the research, they can certainly find hypophosphatasia and see some of these findings. And that's one of the reasons why I'm, again, thinking maybe I need to publish a paper on this, because this is
Yeah.
pretty, because I'll be honest with you, like I said before, I was involved in a study and Dr. White approached me about hypophosphatasia. I was like, what? I had no idea.
Yeah. Well, to your point, I think that, we were actually talking about, using the contents of this webinar to create, an eye fact sheet, working with you, something that patients can take to their doctor. I think that would be a really
Sure.
great outcome of this webinar as well.
Absolutely.
There's a couple more questions, and I want to make sure I get to everybody before we break out into our groups.
Sure.
Is there a system that would indicate those the angioid streaks?
I'm not sure I understand the question.
I think, is there a anything that we as patients, first of all, should be looking for,
Oh,
or
yeah,
is there a
sure.
test maybe that we should be asking?
So I would tell you the biggest thing that you should be looking for are sudden changes in your vision.
Okay.
And particularly with, again, optic atrophy and also with the angioid streaks.
Okay.
That would be something you would definitely want to get in to see your eye doctor. It's not an emergent situation, but certainly you would want to get in to see them quite quickly. That would probably be the main thing. Again, the calcium, certainly you can have maybe a little bit of irritation, but not likely. The biggest, I think, symptom that patients would have would be, again, vision decrease.
Okay. There's a couple questions just about having HPP and whether or not it can either cause early onset of other eye diseases like cataracts, or potentially be mistaken for other eye conditions like early glaucoma. Any thoughts on either of those?
Yeah, I would tell you that none of my patients, and again, it's skewed because of the patient population that I see in the pediatric group, but I have seen no evidence of any other eye diseases like glaucoma or cataracts that patients with HPP would have a higher risk of any of those developing.
Okay. And then another question, can calcifications cause irritation in the eyes?
So generally speaking, no. I would say there, and I'm not even speaking specifically for HPP patients, but there are certainly adults who have calcium deposits unrelated to HPP who do sometimes complain of irritation. And so that would be the one instance where I would maybe have those deposits removed by your ophthalmologist. That would not be something that an optometrist could do. That would be an ophthalmologist. That would be one of the few reasons to consider surgical removal. But to answer the question, yes, in some cases, people do get some irritation from these deposits.
Great. Well, that takes us through all of our questions. So Dr. Rowell, thank you so much. This has been so eye-opening, no pun intended.
No pun intended, right?
And we really appreciate the time that you've taken, and your explanations are very clear, and direction is very relevant to all of our patients. So thank you for that.